Hi everyone, and welcome back to Med Talk. This is Dr. Joseph Motta. I'm a board-certified urologist and urological surgeon here on beautiful Staten Island. Today I want to talk to you about a topic that just hearing the term makes a lot of people wince in pain, and the topic is kidney stones. Kidney stones are very prevalent or very common in the United States. About 12% of the population in the United States has kidney stones at one time or other, including myself and more recently my son Joseph, who underwent 3 kidney stone attacks. But what causes kidney stones? Well, kidney stones most commonly are caused by a lack of fluid intake, that is, not drinking enough fluids. Another common source of kidney stones is too much salt intake in our diets. And that's a very common problem in the United States as well. Our diets are very rich in protein, and also diets are very rich in certain foods that contain oxalates, things like spinach, rhubarb, chocolates, and so forth. So prevention is a very common strategy in kidney stones, but nevertheless, there's a lot of kidney stones that happen in our population. So how do we know we have a kidney stone? What do we do about it? What shouldn't we do about it? Let's discuss some of these topics. As I said, kidney stones are very common, about 12% of the population. That's about 320 million people in this country. So a good percentage, of close to 20 million people have kidney stones. The most common presentation of kidney stones is flank pain. The flank or the abdominal pain in the back is the most common presentation. Because of the nature of the stone, it causes something called renal colic. That is, because the stone is trying to pass through the kidney, through the tube that connects to the bladder called the ureter. It's a muscular tube deep inside the body, and once it gets stuck in that tube, patients will experience what's called renal colic. And renal colic is very painful because it is deep-seated inside the body. Sometimes it's mistaken for other problems such as appendicitis or other abdominal pain sources. This can happen in both men and women alike. So, first symptom is so-called flank pain or abdominal pain, or pain that radiates down to the groin. Now, the pain distribution, that is, as the pain moves throughout the body, will tell us where the kidney stone is located. So if the kidney stone pain or renal colic is more towards the flank or in the back, the kidney stone is typically situated higher. As it moves down to try and go to the bladder, the pain will also migrate, and most often it will be like in a belt-like fashion, and it will migrate down to the bladder, to the groin, to the testicle in males, or to the inner thigh, both in males and females. Well, what should we do in a case like that? Well, certainly it's more of an emergent kind of situation, so most patients will go to the emergency room, okay, to be evaluated. In the emergency room, typically some blood work is done to assess, make sure there's not an infection, and most commonly a non-contrast CT of the abdomen and pelvis is done, so-called renal protocol, which most often there's no dye used. The CAT scan is a very sensitive test, and it will typically show a kidney stone to be the source of the pain. Now, depending on the size of the stone, diagnosis will be made, and thereby also a choice or decision will be made whether to admit the patient for treatment or if the kidney stone will be passed. Typically, in over 90% of cases, kidney stones 4 millimeters or less are typically considered to be spontaneous passage. That is, we allow them to pass on their own. Nowadays, the things that we recommend to allow spontaneous passage of a kidney stone are increased fluid intake, a medication called Flomax, which is typically a prostate medication, but it's been shown to allow spontaneous passage of kidney stones, a modification of the diet, and also analgesics, pain medication, okay? And they come in different forms, so-called non-steroidals, things like Toradol or Motrin, or sometimes if more acute pain is necessary to be controlled, well, some narcotic medications will be used. In that case, the patient may be admitted to the hospital for intravenous fluids, pain medication, and if necessary, especially if there's a fever or signs of infection, a procedure will be performed to relieve the obstruction, to relieve the pain, and also to relieve the blockage and thereby the infection. Okay, so let's talk a little bit about the most common sources of kidney stones. Like I mentioned before, lack of fluid intake, high protein diets, and so forth. Those are most common sources of kidney stone formation. Kidney stone presentations we've discussed. Now, what do we do? If the patient has a kidney stone less than 4 millimeters and they pass the stone, then typically in a case like that, what we recommend is some kind of metabolic evaluation of the patient's body chemistry and the stone, if we're able to recover the stone, so we can analyze it and thereby formulate some type of strategy and medical analysis to help prevent future attacks of kidney stones. Okay. Most often, after patients undergo such a dramatic event as a kidney stone passage, they get on board very quickly to try and help prevent future attacks. Unfortunately, this only lasts a few months, and then typically people kind of go back to their typical habits, and not uncommonly, about 50% of the time, 50, half of the time, most patients will form kidney stones again within 1 year. So it's important to have a strategy to help prevent kidney stones, but more importantly is to stay faithful to it. Okay, so let's say they pass the kidney stones, we do an evaluation, we develop a strategy for prevention. That's wonderful. A second scenario is where the kidney stone doesn't pass, or the kidney stone is larger than 4 millimeters, and let's say it's stuck within the ureter. That is, it's just unable to move, and the pain is persistent. The colic is increasing in nature. Something needs to be done to relieve that pain. Okay, a couple of options. Number one, at that point, we could insert a urologist, a board-certified urologist could insert a ureteral stent through something called a cystoscopy, which is a flexible camera that's placed into the bladder, and then under fluoroscopic guidance or X-ray guidance under anesthesia, a ureteral stent is passed from the bladder to the kidney. That's a very soft, thin stent that stays inside that bypasses the stone so the kidney can drain, relieve the pain, and allow the kidney function to be preserved. At a later time, or at the same time, a procedure called a ureteroscopy can be performed also with a laser to try and break up the stone and allow it to pass. That's in cases where you have a fever, chills, evidence of infection, and or if the pain is so-called intractable, the pain just doesn't go away. If the pain is controlled adequately with pain medication, okay, other options could be used. There's something called shockwave lithotripsy, which I'll go into greater detail, which can be used to break up the stone with ultrasound shock waves without being invasive. That is, no scopes are placed into the bladder, no wires or lasers are migrated or carried up to the stone, and thereby the side effect profile is a lot less. Okay. Now, like I said, if the patient has certain contraindications, like fever, chills, or intractable pain, that's probably not the best therapy. Also, if the patient has certain problems like defibrillators or pancreatitis or pancreatic problems, obviously if the patient is thought to be pregnant, potentially, or if they have a pacemaker or certain other medical issues, that may not be an option, but those are very unusual. Now, if a patient just has a stone attack, and then the stone migrates back into the kidney, or if it has multiple kidney stones, or if they have kidney stones on both sides, where potentially both kidneys may be in jeopardy, then we use this so-called shockwave lithotripsy, and I'll abbreviate it as SWL or ESWL for extracorporeal shockwave lithotripsy throughout this presentation. We may use that SWL procedure to non-invasively break up these stones into soft gravel, which can be passed then by the patient through the normal urinary function. Now, the way this procedure is done is as such. Now, this is from technology that was developed in the 1980s, and at that time, a lot of patients may remember this as being placed into a bathtub under general anesthesia, and the patient used to be in the hospital at least 3 to 4 days. The bathtub is not used commonly anymore. The later generations of these shockwave lithotripters now have gel pads which are placed on the side of the patient's skin. The patient is only given IV sedation, okay, just kind of twilight anesthesia, and the procedure is done, and the patient is able to tolerate it well and go home within 2 hours after the procedure. The procedure itself takes about half hour to 45 minutes. It's over 90% effective in most patients. There are some types of stones that are resistant or they're very difficult to break, but those are very uncommon. Those stones are typically something called calcium oxalate monohydrate. Most stones will be calcium oxalate dihydrate, which are very easily fragmented with the shockwave lithotripsy, and also uric acid stones are also easily broken. Uric acid stones, typically, if they're small, can be treated with medications also. So the procedure is done, okay, the patient goes to recovery room, and then they get discharged home. And the stones, common question is, well, when will I pass these stones? Well, the stones could pass that afternoon, that evening, or in 2 or 3 weeks. It varies on how the stone breaks and how they move around the kidney, and so, quote unquote, drop into the ureter to pass. It's rare, but it happens every so often. Some of these fragments could get stuck in the ureter as they're trying to pass down. And rarely we have to place a stent to bypass that. Or if the urologist thinks that given the size of the stone or the way they break, a stent may be placed beforehand to try and prevent a blockage. Again, that's very unusual because the stent itself, even though it has its benefits, it does tend to irritate the lining of the bladder and cause some urinary symptoms in patients. Also, because the stent keeps the ureter open, it may give what's called some reflux of the kidney, where the urine backs up and can give some back pain. So stents are uncommonly used when we do shockwave lithotripsy. If we feel that a stent is more indicated, or if the stone is at a point where it can be easily accessed, at that point we'll consider strongly to use ureteroscopy, which is the camera, the thin camera that's placed up the ureter, and using a laser to fragment the stone and remove it. Unfortunately, in those cases with the ureteroscopy and laser, a stent has to be used primarily all the time because there's some potential damage done to the ureter when the laser is used, and that's why we use the stent to allow some healing of the lining for a week or two. The stent itself is typically removed in an office setting, okay, with some IV sedation or just local anesthetic gel. And it does serve its function, but again, it's something that we try not to use very commonly. So the patient has the procedure, like I said, the stone is fragmented, and this is done in real time. We use fluoroscopy or X-ray, real-time X-ray guidance when we do this procedure, or sometimes also ultrasound guidance is used depending on the stone and the preference of the urologist. So we can see actually the stone being fragmented or not, okay, or to the extent that it fragments. Then a KUB or an X-ray is done within 2 weeks after the procedure to see if the fragments have moved, migrated, or if the stone has passed. Typically, the patient will be the one that will tell us if the stone has passed. They'll bring in gravel. They are sent home typically from the hospital with a urine strainer, which is a small paper cup with a kind of a sifting mechanism. So when they urinate through that, it'll grasp the stones, because that's important to have the stones and the fragments of the stone for them to be analyzed for a stone chemical analysis. And like I mentioned before, with that, we can formulate a strategy to help prevent further stones. Certainly the most important part of the strategy is drinking plenty of fluids. And a lot of patients always ask me, well, Dr. Motta, how much fluid should I drink? Well, one indicator that you're drinking enough fluids, if your urine color is a very light yellow color, that will be a great indication that you're well hydrated. Okay, if your urine color is dark, like the color of apple juice, you're dehydrated, you're underhydrated. Okay, if it's just yellow and you're forming stones, or you have a tendency to form stones, you need to increase your fluid intake. What helps also is adding some citrate or lemon juice or orange juice to your daily intake, either mix it with water or otherwise, and because the citrate helps prevent stone formation. So that's a common therapy that we'll give before and after procedures once the stones have been fragmented, but to help prevent further stone attacks. Remember that when these stones are fragmented to soft, fine gravel, some of this gravel lays back in the kidney and can be the source of further stone formation. That's why the fluid intake has to be increased to flush out those remaining fragments that we won't be able to see with x-rays or ultrasound. In addition to that, we want to make sure that the patient is well hydrated, because being well hydrated not only is important to prevent kidney stones, but also it's really important for overall good health. Okay. Now, there are some unusual situations. So those are the most common situations. Most often stones are treated with shock lithotripsy, occasionally with ureteroscopy and laser and stent. There are the occasional times when the stones are so big that those therapies are really not going to work, or they may take many treatment sessions to break those. Sometimes we use what's called a percutaneous nephrolithotomy. Percutaneous means through the skin, so a probe is placed through the skin into the kidney. This is done under anesthesia, done by an interventional radiologist typically. And then the urologist will bring the patient to the operating room the next day, and under anesthesia will enlarge that tract from the skin to the kidney in order to put a camera tube, a nephroscope. Through that nephroscope, which is the size of a large pen or even larger, we place various instruments, including lasers, okay, in order to break up the stone, and then using a suction instrument to suction out the pieces. Because it requires general anesthesia, requires now placing large cameras into the kidney, through the kidney, there's obviously a little risk for potential side effects, including bleeding. But in that case, it's really the best and only way to remove all those stones, especially if those stones are causing kidney damage, obstruction, bleeding, and potential for infection. It's extremely rare nowadays to use open surgery, that is actually making an incision, like formal surgery, and opening up the kidney to remove large kidney stones. The only time you would contemplate something like that if a patient has a very large, called staghorn calculi, where the stone occupies the whole portion of the kidney. Okay, then typically that can also be done using percutaneous nephrolithotomy in sessions. But overwhelmingly, for over 90–95% of the stones, a combination of shockwave lithotripsy or ESWL and or the occasional ureteroscopy, laser, and stent will suffice to treat all these stones. The rest can be treated either by observation. Now, what do I mean by that? It's not necessary to treat all kidney stones. Some people may have stones. They're not really causing a problem. It's just an incidental finding. And given their health status, they may have other problems. They cannot have a stone procedure to break up the stone, or if they wish not to do it because they haven't been bothered by it, we decide to watch them. So we may check an ultrasound and or an x-ray every 6 months or once a year just to monitor the status and growth of the stones. And typically a kidney function blood test, like a creatinine level, is done at least once a year to monitor, make sure there's no progressing kidney damage. And I keep going back and forth with patients all the time. The main thing is prevention. Plenty of fluid intake, keep your urine color a light yellow, avoid high salt diets, avoid high protein diets, and avoid certain trigger foods if you wish, things like chocolate and spinach and so forth, green leafy vegetables. Now, when I say that, I get some feedback saying, well, I thought green leafy vegetables were good for you. Absolutely they are. But some, especially in patients that are prone to kidney stones, unfortunately may cause further stone formation. So the one I usually recommend to kind of limit or avoid is the spinach, because it has the highest oxalate concentrations. But I certainly strongly recommend for people to eat green leafy vegetables for other beneficial purposes. So let's take a case scenario of a patient, a common patient. 55-year-old gentleman or young woman is admitted to the emergency room complaining about 3 or 4 days of back pain. But in the past 15, 16 hours, the pain has gotten really intense. The patient cannot find a comfortable position, and if really finds himself more comfortable, kind of lying down on the floor and finding some awkward position to achieve comfort, okay? That's so-called renal colic. Patient describes an episode or two of blood in the urine. So, he's not a smoker, he goes to the emergency room, they rule out urinary tract infection by urinalysis, they do kidney function test and the creatinine level is normal. The white blood cell count is a little bit elevated, but there's no evidence of infection. They do a spiral CT, a 7 millimeter ureteral stone, upper ureteral stone is identified. The patient receives some medications, Toradol or other medication, the pain subsides, and later on it comes back. Because of this breakthrough pain, the patient is typically admitted to the hospital for pain management. IV hydration is started on Flomax to hopefully help pass the stone. Now, 7 millimeter stone, unlikely it's going to pass, especially since it's stuck at the upper portion of the kidney. One thing that's important to understand is as the ureter, the tube from the kidney, travels down to the bladder, it gets smaller and smaller, or narrower and narrower. The channel gets smaller. So if that 7 millimeter stone is stuck at the top of the kidney, of the ureter, the further down it goes, the narrower the passage is going to get. The passage goes down to a level about 4 millimeters. So unlikely that stone will pass. So the options in this case are to intervene, place a ureteral stent under anesthesia, and then use shock waves to break up the stone at a later time, that is, relieve the pain with the stent, or to bring them to the operating room and through a camera, travel all the way up to the stone if possible, use a laser to fragment the stone and flush it out, and pass a stent to allow the kidney to heal, okay? So those are two options that can be done. Let's say another case scenario where the patient goes to the emergency room again, has 1.2 centimeter, or in this case, a 12 millimeter stone that's found in the kidney. The pain has subsided, and now the patient's stone is in the kidney. It's not causing a blockage or obstruction. That patient is better served with a shockwave lithotripsy procedure at a later time because he's free of danger, he's not obstructed, he's not in pain anymore, and he could be conservatively scheduled for shockwave lithotripsy at a later time. The option of putting a stent may be provided at that point in case the stone breaks, but a stone of 12 millimeters should be fragmented and should do okay. Okay. Now, another case scenario is if you have a patient that has bilateral kidney stones, that is, kidney stones on both sides. Let's say 7 millimeters on one kidney and 8 millimeters on the other kidney. Well, they're not causing any problems. These are just incidental findings done for a CAT scan for other reasons, for abdominal pain, but they just happen to find both stones. We recommend in a case like that at least one of the stones be treated so at least both kidneys aren't placed in jeopardy. The preferable thing to do would be to treat both stones at 2 separate sittings, but at least one should be treated to allow it to pass and at least both kidneys are not placed in jeopardy. It's very rare, but it happens, and I've seen it a few times, where both stones drop and both kidneys are blocked by stones, and then the patient goes into complete kidney failure because both kidneys have been obstructed at the same time. Now, fortunately, if that's recognized right away, the blockage can be resolved by placing stents, and the kidney function can be resolved also, and then the stones can be treated. But it's rare, but it does happen. It does happen. Now, something that's very important, I alluded to before, is a stone chemical analysis. We use also something called LithoLink, where we provide with the patient contacts with a company that will ask the patient to do a 24-hour urine collection. The urine tests are sent out for the analysis, and where they actually provide an analysis of all the electrolytes and minerals in the urine and so forth, things like calcium, magnesium, and so forth, the uric acid, to see if the patient is at higher risk to develop stones. Based upon that, the typical recommendations I mentioned before can be done, Or occasionally, certain medications have to be added for the patient to help prevent these. Things like hydrochlorothiazide, if they produce just too many substances that require a diuretic, or if they require more potassium supplementation, thereby potassium citrate, if their urinary pH or the acidity of the urine has to be increased. For example, patients with uric acid stones have a very acidic urine, and they form uric acid stones. By increasing the pH of the urine, that is removing some of the acid, we can help melt some of these stones and thereby also prevent these uric acid stones. But in conclusion, please remember that kidney stones, although they're very prevalent, they're very common, they can be prevented. It really requires you to follow a lifestyle change. A lifestyle change meaning a lot more fluid, which is overall good for your overall health, less salt, not so aggressive protein diet. I know that's common sometimes with these weight loss strategies, but be careful of that because a lot of protein causes severe dehydration and kidney stones. Removing certain trigger foods like spinach and so forth. Cranberry juice doesn't really have much of an impact for kidney stones, but if you like it, that's fine because it allows you to drink water. And avoiding grapefruit juice also is one thing that I neglected to mention before. Grapefruit juice has a higher tendency to form kidney stones. So people that love to drink grapefruit juice have a higher incidence of kidney stones. Other things like coffee and tea are okay, but they are diuretics and they help you lose more water. So be careful about that. Adding lemonade or citrus, things like orange juice, greatly enhances the so-called solubility of stones. Thereby, the stones are not hard. They don't precipitate. I'm using chemical terms, but essentially what that means is that the crystals don't drop down and come together and form a stone. They'll become soluble, and thereby they'll be urinated out. And that's very important. I mentioned a lot of the case studies, but it's important that we don't want to be one of those case studies because they're very common, okay? A lot of patients feel that the symptoms are related to potentially causing other problems like kidney damage or kidney failure, and that's extremely uncommon nowadays, okay? In the past, 40, 50 years ago, kidney stone attacks, unrecognized, were a common source of potentially kidney damage or kidney problems. They're not related to kidney cancer or developing or other kidney problems. It's just more painful and very dramatic pain, unfortunately. Having gone through it myself, having seen my son go through it, and obviously as a urologist, treating 400 or 500 patients per year with this malady, it's a common source of problems. So with that, I thank you once again for joining me today. I hope I've answered all your questions or questions you may have, and I'll look forward to seeing you very soon. This is Dr. Motta with Med Talk. I wish you all the best, and God bless you all.